Good evening and welcome. Tonight, we acknowledge that we and our homes are located on Treaty 6 territory and homeland of the Métis. I am Arla Gustafson, CEO of the Royal University Hospital Foundation. From my home to yours, I want to thank you for your ongoing commitment to women's leadership in healthcare as a WLP member and extend my warmest welcome to the many, many guests who are joining us this evening. It is surreal to think that almost a year ago, we were gathering virtually for the first time. Although we have enjoyed our virtual meeting platforms, I look forward to seeing you all in person in the near future and sharing in the excitement and the enthusiasm each of you have for WLP and the impact that comes with this program. I am always inspired to be in the presence of so many women leaders who have taken the time to give back through our Women Leading Philanthropy program. You should all be so proud that our WLP grant is 100% donor funded and celebrate the impact your investment has made, not only in our community, but beyond. Thank you. Tonight's celebratory event is being sponsored by EY LLP. Thank you for being our meeting sponsor tonight. Representing EY this evening, please welcome Irene Boychuk to the virtual stage to say a few words.
Thanks, Arla. As mentioned, my name is Irene Boychuk, and I'm an assurance partner at EY Saskatoon. I'm also the chair of the Royal University Hospital Foundation and have been involved with the board for several years. As well, I've been a Women Leading Philanthropy member since the inception of the program. EY is thrilled to be a meeting sponsor of the WLP June event. Just like the RUH Foundation, EY knows the importance of gender equality and creating opportunities for women so that they can shine. Every organization is on its own diversity and inclusion journey, and we've been on ours for the last 3 decades. Through our global platform called Women Fast Forward, we continue to work hard to create diversity in the business and entrepreneurial community and in our own workplace. Because we know that gender equality is not a problem to solve, it's the solution to some of business and society's most complex challenges. Women bring diversity of thought to the table, helping business and organizations make better, more well-rounded decisions. At EY, we know that healthcare and innovation is critical in order to keep advancing better access to protocols and research which will impact women's healthcare and treatments available. Since the inception of the WLP program, I've been continually impressed with the level of passion, knowledge, and desire for change in healthcare exhibited by the WLP member, grant recipients, and finalists, and look forward to hearing about the progress of the work performed at each WLP meeting. I'm thrilled to be here representing EY, and I'm happy to be part of a community of women who not only supports but empowers other women to help transform healthcare sector and beyond. Thank you.
Thank you so much, Irene. And please pass along our appreciation to your colleagues at EY for their commitment to advance gender equality. 3 years ago, our WLP program officially launched to advance women's leadership in healthcare, and this evening you will have the opportunity to hear from past grant recipients whose projects have moved forward in one way or another because of your support and investment in WLP. I am so pleased to let you know that our upcoming $100,000 WLP grant for 2022 closed a couple of weeks ago, and we were absolutely thrilled with the number of requests and the caliber of the projects that were submitted. We're excited to tell you more about the applicants over the upcoming months through the WLP Facebook page. Be sure to join if you have not had the opportunity to do so already. I want to take a moment to thank the WLP Steering Committee members who believe in this program and work to advise us and to lead us forward. Kaylin Schrader, Michelle Primo, Diane Pereira, Nicole Payne, Sonia Lee, Angie Hicks, and Lisa Collard. Thank you for your time and your commitment and for believing in the success of this program. And now, I'd like to welcome WLP's Honorary Chair, CEO and Founder of Hilberg & Burke, Rachel Melke, and Program Chair Dr. Mary Kinlock, Division Head, Anatomic Pathology for the Saskatchewan Health Authority, as your hosts this evening. Your leadership is invaluable, and we would not be more grateful to have you as a part of this group. I am hopeful that we will see one another in person at our September 27th meeting.
Thank you so much, Arla. And I just wanted to say welcome to everyone who is joining us virtually tonight. I am so thrilled that you've decided to spend your evening with us. I know I personally feel so incredibly honored to be a part of this incredible program. It's been amazing to see over the past couple of years the journey of from the pitches to the women who are leading these projects to the results that are being achieved, all because of each one of you. So thank you so much for being a part of this again tonight. I'm so grateful that you're here, and I'm excited for an incredible night.
I agree, Rachel. The participation, especially that the commitment our donors have shown us over the pandemic, has been wonderful. And it has been amazing to see women continually step up and put projects forward despite living and working in medicine through a pandemic. So we are very fortunate to be here tonight.
So tonight's program would not be possible without the incredibly generous support of our sponsors. And I just want to acknowledge and thank EY for their generous contributions, 1330 Creative Studio, Humanly Branding and Marketing, D&M Images, Handy Special Events, Plant Van, and last but certainly not least, I want to acknowledge Sky Planning Group and Tracy Duff for her commitment to WLP as a program sponsor. Tracy, you are so passionate about WLP, and I look forward to hearing a few words from you this evening. Welcome, Tracy.
Good evening, Women Leading Philanthropy, donors and participants. I'm so excited for tonight. I also want to introduce you to my little girl. She arrived at my house this year in January. She's 5 years old, and she came with the name Sky. So how fitting is that? But tonight is about Women Leading Philanthropy, and I'm so excited. We are people, empowering people, and we're empowering women initiatives in the healthcare. We're empowering doctors to complete the research that we need them to do, and those doctors are passing that research back to our donors through research and results. To our donors, tonight is going to be a blast from the past, and it's going to be so nice for you folks to be able to hear about how the dollars have been used in our research and our women initiatives for the WLP. We're going to get to be able to be part of a group. And this is why some of us are part of this, is because we do get to hear about the ongoing research and we get to be updated about what is happening. So we wait for September. Good luck to the applicants. And for now, we're going to pass it back to Mary and Rachel so that we can hear about some special things that have happened above and beyond our regular participants. So good luck, everyone, and good night.
So thank you so much, Tracy and Sky Planning Group, for your incredible generosity and dedication to Royal University Hospital Foundation and Women Leading Philanthropy. Your enthusiasm for Women Leading Philanthropy is infectious.
Yeah, I just want to echo that, Tracy. You've been such a champion of this program, and you've been the program sponsor, and we couldn't have done it without you. So thank you so much for your continued commitment and dedication to this incredibly worthy cause.
So it's always thrilling to come back and touch base with everybody to hear about the updates from the successful candidates that have won the $100,000 Women Leading Philanthropy grant. And I know how hard it is to just pick one with so many deserving applications and female physicians that have pitched forward their great ideas. So we thought it would be really great if we heard from some of the amazing women who didn't receive the $100,000 grant through Women Leading Philanthropy and learn what's happened since they pitched their idea to us and how things have evolved. So I'm excited to introduce you to the first ever grant applicant to present to Women Leading Philanthropy donors, Dr. Susan Tupper. And her project, Virtual Reality and Online Training for Older Adult Pain Assessment and Management, New Resources for Healthcare Quality Management. And some of you may not have been Women Leading Philanthropy donors in 2019, so we will reintroduce you all to Dr. Tepper's project by playing her original video from her grant application and follow up with a project update. So welcome back to the stage, Women Leading Philanthropy applicant, Dr. Susan Tepper.
My name is Susan Tepper. I'm a physical therapist with a PhD in community health and epidemiology. I'm the strategy consultant for pain quality improvement and research for the Saskatchewan Health Authority. Our research project is entitled Virtual Reality and Online Training for Pain Assessment and Management in Older Adults, New Resources for Healthcare Quality Improvement. The idea for this research has been a few years in the making. We began a few years ago by doing chart audits in RUH to take a look at how pain was being managed in medical and surgical wards. One of the issues that we found with these chart audits was that pain was not being assessed appropriately for older adults with dementia. And on interviewing the nurses, we found that they weren't aware of some of the newer tools that could be used to assess pain in people who can't self-report. These tools include observations of behaviors. So for people with dementia, they may experience pain, but they don't know how to express it. They can't answer questions like how much is your pain on a scale of 0 to 10, or is your pain mild or severe? They don't have the capacity to answer those questions. And so when they experience pain, they usually use aggressive behaviors, or they may socially withdraw. They may not want to eat. It can contribute to the development of falls, even loss of independence, so they can't self-care, they can't dress themselves, they require higher needs from the healthcare staff. As well, they get very angry and aggressive, and they may believe that when a healthcare provider is coming to provide care for them, that it's a harmful behavior, and so they don't understand that the healthcare provider is there to help them. Sometimes these behaviors are misunderstood as being a result of cognitive decline, and so people are given physical restraints or prescribed antipsychotic medications instead of appropriate pain management because the pain is being missed. Our staff who receive this training will be able to more quickly recognize and more confidently treat pain in older adults, particularly those with dementia who can't provide self-reports. By training our staff to identify and manage pain in the most vulnerable of our population, we're improving pain management practices across the spectrum of care.
My name is Tracy Danilishan Laycock, and I'm one of the behavioral consultants for the behavior support team for the 30 long-term care homes in Saskatoon Health Region. Part of my job is to come in and do behavioral assessments for residents that are displaying responsive behaviors. And responsive behaviors from individuals with dementia are those behaviors that are trying to tell us that there's something wrong. Often they're displayed as hitting, kicking, scratching, biting, particularly targeted at care staff during care. Providing staff with VR training will significantly improve the quality of life of residents living in long-term care. Not only does it decrease the number of trips to the acute care sites, but it also helps staff manage in-home the pain that our residents with dementia, and oftentimes who can't speak, and are telling us through behaviors that the pain is there. And so when staff are easily trained, they're able to spot it faster, they're able to treat it, and it doesn't disrupt the quality of life of the resident in long-term care by having to transfer them to acute care.
Our project is achievable, sustainable, and innovative. We have the right people working together on our research team and our working group. We have the support of the organization, and we have a creative idea. This is an idea that's not just going to transform care in Saskatoon area and RUH and surrounding long-term care homes, but it's going to be an innovative addition to the knowledge and way of delivering education around pain management for older adults throughout Saskatchewan, across Canada, and internationally. Thank you very much to the Royal University Hospital Foundation and to the donors to the Women Leading Philanthropy grant. This is really exciting, a great opportunity for us to come to present our research to the funders for this grant, and we're really excited to share our program of research with you. Over the last few years, we've done lots of work with our project, Initially, we proposed to work with healthcare providers and to provide education on how to assess pain in people living with dementia. But after the Women Leading Philanthropy grant proposal, we refined things to focus more on family caregivers. So we submitted a proposal to the Saskatchewan Health Research Foundation, and were successful in getting a grant with SHRF and with the Centre for Aging and Brain Health Innovation. And with that funding, we have explored the learning needs and pain management needs of family caregivers and people living with dementia, and have conducted interviews and developed a learning curriculum. We were also, thanks to the support of Arla Gustafson and the Women Leading Philanthropy and RUH Foundation group, we were able to get some additional funding from the University of Saskatchewan College of Medicine from a philanthropic donor. And together with the pooled funding from the two different grants, we have been able to develop, we have funding to develop 4 virtual reality videos. One on teaching family caregivers how to recognize pain in people who live with dementia who aren't able to self-report. And then we have 3 experiential videos. One will be at Cranberry Flats, leading people through a gentle movement exercise and a gentle guided breath control exercise, and more experiential and relaxing beside the river and on the beautiful hills of Cranberry Flats. We have another video that's at a ranch with 14 horses, and it's kind of a pet therapy where you get to watch the horses being groomed and tacked. And then we'll have one other experiential video where the person watching the VR video will feel like they're in the middle of a choir, so they'll be surrounded by singers. Unfortunately, the filming of a couple of our videos has been delayed with COVID, but we're well on the way to finishing up those 4 videos. And here's a 1-minute video showing part of what you might see on the virtual reality headset. It moves around a little bit, so you'll see wherever you look, you see a different part of the ranch, kind of as if you were there. And that's the beauty of virtual reality, that it makes you feel like you're embedded in the environment. So in this video, we visit the ranch and watch the horses being groomed and tacked, and we get to watch the horses riding around the arena, and also get to visit the horses and hear their stories out in the pasture. So here's a 1-minute video showing that.
Let's head into the barn and get Doc and Shadow ready to ride. Welcome to the barn. This is Doc and Shadow, 2 of our horses that we ride almost every day during the spring, summer, and fall. Doc and Shadow have been waiting in the pen for us to get them so they can have some fun today.
So once we finish recording the 4 videos, we're going to be recruiting participants to get their opinions on the videos and their perspectives, and find out what the impact of the videos are on pain and mood and overall well-being. And we're looking also as to whether or not there's any side effects and who benefits from the virtual reality videos, and maybe who might not benefit as much. So we'll be looking at that. And the next steps are, we want to work with family caregivers to develop more materials to build capacity to assess and manage pain in people living with dementia. And we'd also like to roll these use of the virtual reality videos out into the Saskatchewan Health Authority, into long-term care homes and personal care homes, and work with recreation therapists to develop this research further. So we'll be looking for additional funding for the next steps of the research, and we're really looking forward to continuing this on. And very grateful again to the RUH Foundation and to Women Leading Philanthropy for helping us find the additional funding. Thank you.
Thank you so much for sharing that update, Dr. Tupper. It's incredible the progress that you've been able to make on this project. And it was so interesting to hear the details of how this is starting to evolve and roll out. I couldn't help but feel emotional when I was listening to you and thinking about the impact that this could potentially have in not only communities in the province, but quite honestly, like a wider application for people across the globe. So wow, it just honestly, it reinforces the power of these projects and how important they are to the communities that we live in, and how there's such a wider application for them as well. So congratulations on all the work that you've done. And I can't wait to hear more of how this evolves in the future. I know that many of you will recall Doctors Prokopchuk, Gok, and Harding's PRAM project from the inaugural WLP grant year. I am so excited to welcome them back to the WLP stage for an update and to find out where their project is today. Let's start by revisiting their initial video.
I'm Dr. Oksana Prokopchuk-Gauk. I'm a clinical hematologist and transfusion medicine physician with the Saskatchewan Health Authority. My role primarily includes transfusion medicine consultancy in Saskatoon, as well as for Northern Saskatchewan. I joined the Department of Lab Medicine and Pathology in 2016. We have recently received support from the Ministry of Health for the establishment of a perinatal testing program called the PRAMS program. PRAM stands for Prevention of Alloimmunization in Mothers of Saskatchewan. This program will be focused on helping women to be followed during their pregnancies and after pregnancy to ensure that there are no complications that arise, that they receive appropriate treatment if they are Rh negative or if they have antibodies. And specifically, these antibodies would be directed against surface markers or proteins on baby's red blood cells that may cause rejection of that baby if not treated properly.
I'm Dr. Sheila Rutledge Harding. I'm a hematologist in Saskatoon. I've been here since 1988. I'm currently the division head for transfusion medicine. Part of what this system will do for us is to alert the nurses that are associated with the program to the need for follow-up of mums and babies that have had interventions. So for example, a baby who's required transfusion in utero has very special transfusion needs for 6 months following their due date. And we need to know that those babies are in that category, regardless of where they show up and regardless of why they're seeking medical care. At present, they're at real risk of being missed.
This database will allow us to extract information not only for the immediate care of those patients, but also for research purposes to make sure that we are able to know exactly how many women are Rh negative, who received the appropriate doses, is there any way to optimize the care that we have established at the moment, and how can we get better as time goes on to make sure no one is missed and to ensure that these antibodies are prevented to allow for women to have successful pregnancies hereafter.
At present, a woman in La Ronge who is found to be pregnant will have blood samples sent from La Ronge to Regina to Vancouver for testing. That already builds in delays. The results from Vancouver will be sent back to the ordering provider and to the hospital that they anticipate will be the hospital for delivery, probably Prince Albert. That said, our patient from La Ronge might be visiting her cousin in Estevan when she goes into labor and may end up delivering in Regina, where they don't have access to that necessary information, leading to delays in care and the potential for errors to be made.
When I look 5 or 10 years from now, I see that the issue of alloimmunization in pregnancy will be one that we've wrestled to the ground. Every Rh negative mom gets the preventative care that she needs. Every alloimmunized pregnancy gets due care and attention so that babies are well served, they're born healthy, they get good follow-up for as long as they need it. And there aren't any of those disquieting stories of things that went wrong because information was missing.
The real success in this case will be making sure that we have the information that we need at our fingertips. This will help to optimize care for our women, prevent retesting, prevent delays in care because of needing to acquire paper-based lab results or make phone calls one-to-one. The information should be available in that computer system, in that database, to allow for care to be expedited should that woman deliver her baby or require care in a center outside of the originally planned center of delivery.
We are very grateful to Women Leading Philanthropy for the opportunity to apply for this grant and very excited to have been shortlisted. We have a great team of lab directors and managers and transfusion medicine consultants who are very keen to get the PRAMS program underway.
Thank you, Rachel. Watching that has reminded me of how far we've come since then. Before I turn things over to Dr. Prokopchuk-Gauk to tell you about the successful implementation of the PRAMS program, I'd like to explain just two of the ways in which our participation in the Women Leading Philanthropy process helped to ensure our success. Writing our proposal forced us to think long and hard about what we really needed our active information network to do. Thus, we were well prepared to recognize the solution when it presented itself some months into our planning. We received very helpful coaching while writing our pitch script. We then had the opportunity to recruit a rock star project manager. Before I met with her, I sent her that script. She arrived at our initial meeting already convinced of the importance of the PRAMS program. She came aboard, and the rest is history, as my colleague will describe in more detail. Thank you.
Thank you, Dr. Harding, for explaining how the Women Leading Philanthropy grant application process helped to shape the future of our PRAMS program. I'm Dr. Oksana Prokopchuk-Gauk, and I am grateful to the WLP for giving us this opportunity to provide you with an update on the PRAMS program. As you will have heard in the video, pregnancy is a time when antibodies against red blood cell surface proteins, or antigens, can form. Care standards outline that basic blood bank testing must be done, including an ABO group, Rh type, and antibody screen. Significant results require follow-up in terms of additional specialized tests and clinical management. For context, I'll briefly provide a timeline on why the PRAMS program was established. Canadian Blood Services Diagnostic Services Lab in Regina previously offered routine testing for pregnant patients in Saskatchewan. At their decision, the Regina lab closed in fall 2017. This led to a joint business case submission from Saskatoon and Regina Transfusion Medicine Services to the Saskatchewan Ministry of Health to repatriate testing of about 22,000 samples per year back into the province. The business case was accepted in principle, but a program was yet to be established to support this transition. In the meantime, samples were sent to CBS Vancouver for centralized testing and reporting, though this was non-ideal due to the time delay in result reporting because of travel and paper-only reports provided to clinicians. The establishment of the Saskatchewan Health Authority led us to review our original testing business case. In 2018, Dr. Harding and I submitted an application to the WLP for a grant to support an active information network as a component of the PRAMS program. Although our application was unsuccessful, it led our team to consider alternative options, which were within our allocated budget from the ministry. Within PRAMS, our main goal is to reduce the risk of red blood cell antibody formation in pregnant patients. This required three main project phases related to lab testing repatriation into hospital labs, information integration and database development to support information flow for patient care, which was the focus of our WLP grant application, and the development of comprehensive clinical programming for Rh-negative and alloimmunized pregnant patients. As you can see, the information integration and database formation is the key linkage in the center between lab testing and clinical program components. We used a decision-making framework and process to determine the lab testing model that would best support the identified priorities for PRAMS, which aligned with SHA values. Lab testing model options were reviewed and ranked based on weighted scores provided by Saskatoon and Regina transfusion medicine physicians, with the final decision resting with the PRAMS steering team. Our final approved testing model was implemented on February 3, 2020, and continues to serve our patients today. 3 hospital sites support the main work of PRAMS. Prince Albert's Victoria Hospital supports patients in the far north and northeast parts of Saskatchewan. St. Paul's Hospital in Saskatoon supports patients from central and northwestern portions of the province. And the Regina General Hospital supports patients in the south. Royal University Hospital in Saskatoon supports specialized tests, including prenatal antibody identification and titers for all patients. The transition was relatively seamless and has led to notable improvements in terms of result visibility in the eHealth viewer and reporting into physician electronic medical records, enhancing patient safety, and faster turnaround times of all results, including antibody titration testing with automated equipment. We are very excited that our PRAMS clinical program has been live since October 2020, following the hire of our PRAMS nurse coordinators. Together, we have been able to adapt the use of ERGO as an electronic medical record system used in physicians' offices to serve as a fully functional active information network for PRAMS. Results of prenatal testing are electronically copied by labs into the PRAMS ERGO profile and then reviewed by our nurses. This allows them to make sure Rh-negative women receive their Winrow and ensure alloimmunized patients are connected with specialized care. In addition, our nurses are able to make sure that babies born to mothers with antibodies are not lost to follow-up. The ERGO system has worked even better for us than imagined, and without our WLP grant application experience, we may not have discovered ERGO as a brilliant active information network solution. I would like to specifically acknowledge Kaylin Paulson, who served as our project manager during the PRAMS program development process, our transfusion medicine colleagues for their support throughout this program establishment, and our PRAMS nurse coordinators, Shaylin and Sandy, who continue to help improve the care of prenatal women on a daily basis. We thank you for your attention and welcome any questions that you may have.
That's fantastic, Sheila and Oksana. Thank you so much. It's I have so much pride seeing your success over the last number of years, and considering that, I mean, Oksana and Sheila and I know each other quite well because we're in the same department, but I don't know that if we realize how lucky we are to have them here and how passionate they are. And it's hard to explain that because what comes out of their success is just that we don't have sick babies. And like, I don't know how to express that in any other more grateful terms than thank you for keeping the children of our province safe and healthy. And so our presenters this evening, Dr. Harding and Dr. Prokopchuk-Gok, and all the other ones welcome any questions that you may have, and they want to engage in a discussion with you specifically because you helped make their project successful. So to allow for sufficient time for each presenter, we ask that you send your questions to info@ruhf.org and then watch the Women Leading Philanthropy Facebook page for answers and ongoing discussions. So now we're going to hear an update from Dr. Susie Harriman on her project Translational Simulation for Trauma in Saskatchewan, Women Guiding Safety, Quality, and Teams. Unfortunately, Dr. Harriman is unable to be with us this evening as she is on a trauma rotation, but we wanted to share with Women Leading Philanthropy donors the unique ways that her project has moved forward.
I am Tanya LaBelle, and this is my husband, Paul. We are the parents of Xavier LaBelle, who played on the Humboldt Broncos. He is a survivor of the tragic Humboldt Broncos bus crash that was on April 6, 2018.
The night of the crash, we were on our way to Nipawin to cheer on Xavier and the Broncos with our 9-year-old daughter, Viviana. Our son Isaac called us and said he'd heard that there had been an accident involving the Broncos bus. Shortly after that, we drove up to the devastating scene. It was about an hour after the crash had occurred. Nothing could have prepared us for the devastating scene and carnage that we saw when we arrived at the accident. Nothing could have prepared us for the trauma that we felt at that moment, or in the days, nights, weeks, months, and even a year later.
We witnessed and experienced the profound effect that trauma has on so many families. We consider the shock and continued trauma for the family members whose loved ones died instantly, the trauma for those whose loved ones struggled to survive, and those who continue to face life-changing traumatic injuries. We recognize that trauma can affect anyone at any time, and that trauma affects victims and victims' loved ones.
We are grateful for the medical care that Xavier received in the chaos that night and in the days following. Considering the multitude of injuries that he had, it's a miracle he survived. Xavier's injuries were so severe that initially he was unrecognizable, and he was misidentified as one of his teammates, Parker Tobin. Communication in the chaos was challenging. Despite the fact that Xavier will have some lifelong injuries to deal with, he's doing amazingly well. As parents, we continue to worry and feel anxiety about how this traumatic event might continue to impact Xavier in his future.
I'm Dr. Suzanne Harriman. I'm a trauma surgeon here in Saskatoon, and my title of my project for this grant is Translational Simulation for Trauma in Saskatchewan, Women Guiding Safety, Quality, and Teams. When we hear trauma team to emergency ring overhead throughout the hospital, we know that every minute counts, and it's potentially our moment to save a life. As healthcare professionals, we accumulate a variety of skill sets. Some of those skills we use on a day-to-day basis in trauma. Some of those skills we use once to twice a year. But when we use those skills, it's in the most dire situation. As a trauma team, we want to be sharp and we want to be ready with each trauma we see, especially when we know in trauma situations, every minute and second are so precious.
I know that working in the trauma environment is often very chaotic and stressful, beginning at the scene, right through to the patient care in the emergency department. Communication, along with identification and treatment of life-threatening injuries, is important for a successful outcome.
If we win this grant, we want to develop a program that takes trauma simulation to the next level. We want to develop scenarios that are intense and stressful, and most importantly, as realistic as possible. This will allow us to identify our shortcomings within the trauma service and hopefully make changes that will improve the quality of care that we can offer trauma patients in Saskatchewan.
My name is Frankie Affleck. I'm the trauma nurse navigator for the Saskatchewan Health Authority. I'm a registered nurse, and my role in healthcare is to coordinate and support trauma patients of Saskatchewan and their families as they progress through their hospital stay. Trauma simulation gives us the opportunity to improve our care. By practicing, we can improve our communication, clarify roles, and look at the processes of how we're caring for that trauma patient in need.
These improvements can only happen if we push ourselves and we strive to make impactful changes. I believe in this project, and I believe in situ simulation will help us be better for the moments that really count. If we can save one life by the improvements we can make, I think we would all think it's worthwhile, knowing full well that that person could be any one of our loved ones.
During the initial chaos of such a large-scale disaster, the misidentification of our son resulted in increased pain and suffering to everyone involved. We believe that increased trauma simulation will provide opportunity for medical professionals to improve team communication and communication with families.
We're hoping that funding for this project will provide opportunities for the trauma teams to work together in lifelike situations to improve outcomes.
I'm a female trauma surgeon in a male-dominated field. The trauma surgeon side of me wants to lead the trauma team to act swiftly and efficiently to have the best outcome. I want to be a mentor to young females to push barriers and break down gender inequalities in trauma surgery. More importantly, as a wife, as a daughter, and a mother of 2 young boys, I want our trauma team to be there in life's critical moments to hopefully lessen the devastation that trauma can have on the entire family.
Preparing for this video has brought back many painful memories for us. Despite that, we are hoping that by speaking out in support of this trauma simulation project, it'll help strengthen the trauma care program. We support Dr. Harriman and the Ms. Affleck and this initiative, and we thank them for their leadership, which will benefit the people of Saskatchewan and possibly even you or your loved ones.
First of all, I just want to say how thankful and humbled I am to be part of such a group of such empowering women. I really believe women are destined to do great things, and when we support each other and uplift each other, and I think that we have the ability to lead with empathy, and that's what will always set us apart and allow us to be successful and help people around us succeed. So what I've learned so much since I presented my project at Women Leading Philanthropy. When I presented, I was eager and motivated, and truthfully probably a little bit naive. I was so touched by the generosity of the labels to be part of my project and to make themselves so vulnerable. And I was really wanted to get the project off the ground immediately. Like everything in life, the barriers started to present themselves, and I really felt like initially I was taking one step forward and two steps back in developing the trauma program, simulation program. I started a position as a postgraduate medical education simulation lead, and I've learned a lot about the education and simulation. I've also taken a course at called Healthcare Simulation Essentials, Design and Debriefing, and this was through Harvard Center of Medical Education. Both of these opportunities became available to me from the support and involvement with Women Leading Philanthropy. The WLP presentation really gave me a great platform to talk about trauma simulation, and I've had several people reach out and want to be involved in various capacities and help the program to be successful. I guess what I didn't initially realize was the leap from medical education in the College of Medicine to the quality assurance and continuing medical education of the Saskatchewan Health Authority. I'm beginning to understand there's different governing bodies that have similar goals of having good patient care, but different means of reaching those goals, different funding models, and kind of different specific goals altogether. When COVID happened, like I'm sure many can attest to, changed the trajectory of our goals quite significantly, and things kind of came to a screeching halt. The simulation center at the College of Medicine closed completely initially, but as things began to develop, there was an understanding that the College of Medicine had resources that the SHA, they had a need and kind of co-aligned to kind of work together to try and fight the pandemic. We began to use simulation for something as simple as teaching healthcare professionals to don and doff personal protective equipment to keep themselves safe. We use simulation in intubation teams so that the healthcare workers involved in high-risk procedures like intubating a COVID-positive patient knew how to keep themselves safe. We also use simulation in what were once familiar situations or scenarios that now became feared or more dangerous because of COVID. And we use simulation to help the healthcare workers kind of understand how to navigate these more difficult situations, such as a cardiac arrest scenario. We saw that people came together, and the value of simulation was really put in the forefront during the pandemic. The buy-in from the healthcare professionals for simulation was astounding, and the success that these simulation experiences had were really quite profound. So in hindsight, the last year of the pandemic hasn't really been all that bad for the advancement of our project, Translational Simulation for Trauma in Saskatchewan, Women Guiding Safety, Quality, and Teams. COVID has highlighted some of the importance of simulation education, and will hopefully put us on a new trajectory towards meeting our goals. My project has not developed the way I hoped it would, or isn't quite where I hoped it would be in the last 2 years, but it has not been from the lack of support and the exposure from Women Leading Philanthropy. With the exposure that Women Leading Philanthropy gave to my simulation project, I have found funding support through different avenues and have had many people come on board to help navigate some of the barriers that we've been challenged with. You know, I'm a little less naive, but nonetheless still eager and motivated that we will have success in developing the trauma simulation program here in Saskatoon. Thank you for listening to this update, and thank you so much for continuing to support females in healthcare, allowing them to lead with their hearts and their mind.
Thank you so much for the update, Dr. Harriman, and your commitment and continued focus and support on taking this project forward. I can only imagine how challenging it was to navigate through COVID and all of the changes and things that weren't able to move forward as you envisioned. But what an amazing story to hear about how you were able to really adapt and use the simulation technology to be able to train people through COVID. What an immediate and incredible result. We continue to cheer you on and look forward to future updates. I can't think of something that's just like so relevant and needed right now that other than this type of AI to train physicians in the province. So as we did in January, we were really excited to have Dr. Laura Hopkins, as selected by you, our WLP donors, here to share an update with us. Her second of 3 updates for this group, enabling you to hear firsthand about the impact of your WLP investment. Please welcome our most recent Women Leading Philanthropy grant recipient, Dr. Laura Hopkins, as she shares with us the progress of her ERAS project.
My name is Krista Harlech, and I am a high school art teacher in Prince Albert, Saskatchewan. And this journey kind of started around the time when I was actually going on holidays, and I ended up going to the Medi clinics. I wasn't feeling so well, and one thing sort of led to another, and it ended up with MRIs, finding that I had some tumors on my ovaries. And then I was referred to Dr. Hopkins, and things really went fast from there. We found out that I had borderline tumors and that my ovaries were going to need to be removed in order to prevent kind of cancer from progressing, I guess. I struggled a lot with kind of emotional and mental anxiety just with everything going on and the possibility that I had cancer being so young. I'm only 29, so it was really hard kind of news to get when I had only gone into the doctor for stomach pains. So it was kind of a really big shock to me to find out that this could be cancer. Throughout all of this, I've kind of realized some things about this surgery. Since I was cut from such a large area, it's kind of amazing how much you actually use all your core muscles. I wasn't really aware of that at first, but doing anything was painful. Rolling over, going to the bathroom, walking, sitting up straight has been a challenge. It's been a really long journey, and I still feel like I'm recovering. I'm a squeamish person, so seeing such a large incision with no bandages on it was terrible for me. It was so hard to even look at it, and I was encouraged to rub it and put oil on it, and just the thought of doing any of that was just so scary for me. So it was very difficult, and still it's a little bit strange because, it's amazing how much nerves get affected in this. I never really thought that was going to be a thing, but there's so much numbness and just doesn't feel like it's part of your body anymore. And it's kind of something that's hard to get through your brain, that this is still a part of me, and this is the new reality, I guess.
My name is Laura Hopkins, and I'm a gynecologist here at the Royal University Hospital. I'm the provincial head of gynecologic cancer. I've been in Saskatchewan about a year now, almost, and our project for the Women Leading Philanthropy grant is called Enhanced Recovery in Gynecology. And this project is intended to improve surgical outcomes for women with gynecologic cancer. And what we intend to do is transform surgical care at the RUH. Our team is made up of doctors and nurses, and we have roles that span the time from a patient being referred to our service for a surgical consultation all the way through to admission at the RUH for surgery, recovery at the RUH, and recovery at home for the first few weeks. And if you can imagine being a patient who's facing surgery for a known or suspected gynecologic malignancy, your life is turned upside down. The last thing you need is a surgical complication. What you really want is an absolutely perfect procedure that goes without any complications. You want to get home to your families as soon as possible. It's not just for most of our patients, but for all of our patients. It's not about meeting surgical standard of care, it's about raising the surgical standard of care. That's the essence of this culture shift.
My name is Carolyn Morin. I'm a nurse specialized in wounds, ostomy, and continence nursing, and I see many patients post-operatively. Post-operative wound complications present a variety of problems. Having people come back in hospital and requiring additional surgery causes all sorts of stress for the patient and cost to the healthcare system. If patients need to go on to have chemotherapy, having a wound can really delay that and adds more stress to an already stressful situation. So anything we can do to prevent complications and ease the transition for people to leave hospital, go home, and then deal with the next stage of their recovery is important.
The ultimate goal of an enhanced recovery pathway for gynecology patients is a normal, uncomplicated recovery from surgery for everyone. The funding is important to do this work because getting a lot of busy healthcare workers to work together, even on something simple, can be a challenge. So we need to have a project manager, basically. So someone to schedule meetings, get us together, work us through all of the elements of ERAS, allow discussion, and allow that wisdom of the frontline providers to inform the ease with which we can implement all the various things that we need to do in this project. Ultimately, this project, if it's successful, it's going to change care across the entire OR. It has been said that the OR is a complex adaptive environment. That's what they teach us at meetings about how people work together. And what that means is that when you change one thing in one place in a complex adaptive environment, it doesn't just happen in isolation. It has ripple effects that change care in other rooms because, for example, nurses move from room to room. They don't just work with one surgeon. They work with many surgeons. And the more education that one team has, the more that they can share that education with others. So improving in one site will cause improvement across all sites because practice will change, the culture changes with it.
I want nothing more than to have other people like me have great experiences in the hospital because I feel that, the threat of cancer is such a big thing for so many people that a hospital stay shouldn't be something that should be worrying them as well.
And we don't need to just do this in gynecology. Remember, we need to do it for everyone. We really need to change the culture because the chance of any one of us having surgery in our lifetime is very high. And there are statistics on this. And every person in Canada will have, on average, 3 surgical procedures in their lifetime. So that means all of us are pre-op. We just may not know it right now. So it's very, very important for us to work collaboratively together to get this project done as soon as possible so we can start changing care now.
Good evening, everyone. It's my pleasure to give everyone an update on our Women Leading Philanthropy Enhanced Recovery After Surgery project work. So the team has been working hard on this for the last 5-6 months now, and we're just about ready to go as planned for our launch this September. We have engaged every frontline provider who's involved in the care of our patients from the time of booking right through to discharge from hospital. And all along the way, we've kept the patient at the center of our focus. And in keeping with that focus, we've created a custom surgical preparation pamphlet or booklet that will explain to everyone who's having surgery with Gynecologic Oncology all about the enhanced recovery after surgery measures, the how, the what, and the why, and take each woman through their care right from the start when they meet us for the first time, often virtually in these times, all the way through to discharge from hospital. And it's our hope that this booklet is going to help our patients stay very connected to their own care, but also connected to their team and to WLP. So we decided to break the project into 3 phases that match the preoperative, intraoperative, and postoperative phases of care. And we decided to standardize our approach and ensure no variation in care by setting up pre-printed orders to match those 3 phases of care. And so in the preoperative phase of care, we focused on identifying and screening our patients for diabetes because we know that's really important for prevention of surgical site infections. So we've got a relationship with our internal medicine colleagues where we make a new diagnosis of diabetes and where there's poor control to ensure that we're able to manage those blood sugars throughout the care continuum. We've also focused on identification and aggressive management of anemia where it exists so that we can optimize recovery and strength after surgery. We have engaged with the preoperative assessment unit and we'll be purchasing 2 Women Leading Philanthropy iPads for use by the patients as they wait for their appointment. And the reason why we did this is because we discovered that the Enhanced Recovery After Surgery Society has a number of online education materials that would be very beneficial to see before going through surgery with our group. So that's the preoperative phase. Now, we don't have pre-printed orders in the intraoperative phase of care. We do, but it has a special name, and it's called the Surgical Safety Checklist. So this is how we ensure that we're going to cover all of the various measures associated with enhanced recovery during the surgical experience. And this is nothing new. Surgical Safety Checklist was endorsed by the World Health Organization back in 2008. And it's been mandated to be used in every hospital OR worldwide since. And it has happened. It's just that the culture of that operationalization is a little different in each site. Now, the roots of the Surgical Safety Checklist are kind of interesting, and I want to just digress with a little story for a second because I think it's fun to know how things started. But the safety checklists have their roots in aviation. And back in the 1930s, Boeing came out with a new 4-engine bomber called the B-17 Flying Fortress. And this plane was much more complex in design and operation than other planes of the time. And they found out just how complex that was when an experienced pilot missed a step during flight and there was a crash. And so when the Army circled around to review what had happened and how to prevent that from happening again, they decided that there were certain steps that were complex and that needed to have proper attention on them. And so they decided to create this series of steps that were required and that would have to fit on a recipe card and that the pilots would use during flight. And once they started using their recipe card checklist, the Flying Fortress had another 1.8 million miles of flight without any incident. And so after that, the Army made it a requirement for all flights, and that's the origin of the checklist. And so we have a similar checklist that we use in the OR, and it is a little different every place. I've operated in 7 different ORs across 3 provinces in the last 5 years, and every hospital does it differently. And you might sit there and think, well, it's probably what it sounds like. It's probably a checklist. But actually, it isn't a checklist in any place. And we decided to use this opportunity with the Women Leading Philanthropy support to develop an actual surgical safety checklist that is customized for gyne-oncology and includes every ERAS measure, or enhanced recovery after surgery measure, on our checklist so that we can ensure that we do not miss any steps. And we're excited to introduce this to our everyday practice starting in September. So that covers the intraoperative phase, and then we've worked on a pre-printed order set as well for the post-operative phase of care. And this one is focusing around the use of multiple different medications that work in different ways that can help each other to minimize the use of narcotics in pain management after surgery. And we are also going to implement a standard measure for assessing pain after surgery, and we're going to be purchasing something called the brief pain inventory, and we'll have every patient who has surgery with us complete this brief pain inventory each day while they're admitted so that we can monitor efficacy of pain relief. And also we're going to have a way of auditing our effectiveness of these new measures that we're going to bring in. We also have other things in the preprint for postoperative recovery, like moving around early after surgery, taking out catheters as soon as possible, and as well taking out intravenous fluids as soon as possible, because these are both linked to delayed recovery. We also have a new order there that will have our patients having a light diet the night of their surgery, as this has been shown to speed the return of normal bowel function. And we're also going to include a dietary supplement of additional protein, because the evidence will show that that protein is very important in healing tissues and in the formation of antibodies that helps prevent infection. So this is an overview of what we've got ready so far. We have our Dean's Award medical student already in health records abstracting data from 2017 to give us a baseline and so that we'll know what our starting point is, how we're doing, and then be able to measure the impact of the enhanced recovery after surgery pathway in gyne-oncology. We plan to launch in September, as I mentioned, and we're going to kick things off, so to speak, with a combined surgery and anesthesia grand rounds. And we've invited a speaker who's very engaged in enhanced recovery measures and is a strong proponent of it to help us celebrate the launch of our WLP project, and hopefully to smooth the transition for everyone, because, of course, working in the OR and having everything be perfect for the patient is so important to all of us. So we're really excited to look forward to the fall. Thanks very much for all your support, and looking forward to the next update.
Thanks, Laura. I can't believe how much you've accomplished so far. And just sometimes I know that it must feel like the weight of everything is falling on your shoulders, that you're trying to do it all. But just so you know that we're all behind you and cheering for you and providing that support to you. And I remember what, my mom always tells me, that if it was easy, then everybody would do it. So you're forging new ground, and that is something that's laudable and difficult all at the same time. And I can't believe listening to these stories of these women, because they get paid the same amount of money whether they do these things or not. Like, these are extra work away from their families, and things that they do not get paid for, just because they care so much about making something not bad happen to patients. That is so important to them, that they want them to have the most seamless experience. And I'm just so touched by the fact, especially by what Susie said, is leading by empathy, because as you notice, the most expensive thing that anybody's bought is an iPad here. There's no like fancy machines anybody's buying. It's just making sure that the patient's experience is going to be the best that it can be as they go through their healthcare journey. So thank you very much to all of you for what you've accomplished and done.
Listening to your update, Dr. Hopkins, it's hard for me not to get emotional, having just gone through gynecological oncology surgery recently. I just want to echo Mary's sentiments to say thank you for taking this project and championing it, and hearing, Mary, you speak about the amount of time and effort and work that needs to go into this to bring it to, my gosh, it's been a year since this kicked off. And really, like, so much amazing work has been done, and it's making an incredible difference in patients' lives. And it definitely hits home for me. So thank you so much. The Royal University Hospital Foundation's Women Leading Philanthropy program exists because of each and every one of you in this room. Over 100 women donors and counting. You have all committed your financial resources, your time, and your expertise. Your philanthropic spirit and your belief in this important work being conducted by brilliant female physicians and practitioners at the Royal University Hospital is why we're here tonight. WLP is designed to engage and empower women in determining how those dollars will be invested. Having a say and a choice in how your dollars will be used is one of the key elements that makes WLP so unique.
And the other truly unique thing about Women Leading Philanthropy is the level of accountability that's been built right into the program. And WLP is your opportunity to invest in a forward-thinking project that will impact the care you or your family may one day receive. And I'm so proud to be part of Women Leading Philanthropy. And I ask you to join me in building and growing our impact. And so starting this evening, until September 27th voting meeting, Affinity Credit Union will donate $250 up to $5,000 for each new member of Women Leading Philanthropy. So when you share your network about how they can join Women Leading Philanthropy, then we can make an even greater impact together. So thank you for being here this evening. I look forward to seeing all of you, particularly those of you who are inspired to be our newest members, back again in September for our voting meeting on the 27th. Stay safe and stay well.